Good evening, everybody, and welcome to the Royal Society of Medicine. We're actually 2 minutes late, so apologies for that. We have about 600 people, maybe 700 people even, online this evening. So the people online, welcome. You're very, very welcome to the Stevens Lecture. Just a few things to mention about the Stevens Lecture. It was Edwin Stevens, who was Lord Stevens' father, who was the inventor of the first wearable hearing aid, and he made a lot of money out of that invention, and luckily he gave some of his money to the Royal Society of Medicine. So since about 1970, I think was roughly the time it started, kicked off, so that's 52 years ago, we've been having Stevens Lecture, and if you look through the list, they have extremely prestigious speakers. But we have a very prestigious speaker here this evening, Professor James Larkin. If I get my glasses out, I'll give you a little bit of an update on James. Pretty distinguished career, I have to say, James. So, Professor Larkin grew up in North Cornwall. Well, there you go, that's distinguished. Taking a first in natural sciences from Cambridge University. That's my university. And then the traitor went to Oxford University to do his clinical studies, qualifying in 1996. Underwent general medical training in London, and in 2001 won a Medical Research Council Fellowship for a clinician for laboratory research at the Institute of Cancer Research. His research interests involved trying to understand cancer and the consequences related to improved treatments and targeted therapies as well as immunotherapies. And this evening we're going to hear about curing metastatic solid tumours with immune checkpoint inhibitors, a reality in 2022. And I see we've got some top brass oncologists here in row 3 who I'm afraid may give us some trouble during the lecture. But I think they would agree that some of the research that James has been involved in is truly transformational. Metastatic melanoma, metastatic kidney cancer was widely regarded by surgeons like me as totally incurable once it had spread elsewhere. The work that James has done has transformed patients' expectations and their relatives, of course. James, over to you.
Thanks very much, Roger. Good evening, everyone. So, actually, Jonathan Waxman and Carol Sakura, who are sitting in row 3, were my bosses on my first SHO job in 1997. I was just catching up with Jonathan before the talk, so I hadn't seen him for 25 years. Anyway, so thank you for coming, everybody. And hi to everybody who's watching the webinar. I'll try not to be too technical. It's quite a technical title, though. And the point of this is that, as Roger's just said, certainly when I was at medical school and when I was training in oncology, the experience was that almost all metastatic solid tumours, meaning that solid tumours that had spread around the body, were incurable, with a few exceptions. So, for example, germ cell tumours. And that is in contrast, for example, to blood cancers like leukemia and lymphoma, which really people have known for decades that you could potentially cure with what you might call traditional chemotherapy drugs, cytotoxic chemotherapies. But those kinds of drugs, although they could help to control metastatic solid tumours, very rarely led to cure. So that's the background, and this is an example of that. So melanoma, a type of skin cancer, metastatic melanoma meaning spread around the body. And certainly when I started treating this disease, probably 15 years or so ago now, this was what survival looked like. And my apologies for those who aren't used to looking at survival curves. I'll just spend a moment going through this. But basically, this is time along the bottom in years. time since the diagnosis of metastatic melanoma, which the stage 4 means the same as metastatic, the chance of being alive here, so at the start everyone's alive, and then you can see that as the curve goes down, what that means is that people were dying of the disease. And the median in the title of the slide refers to this. In other words, the time point at which half the people have died of the disease. And so if you line up there, the median here, you can see that the average life expectancy, which is another way to put this, for metastatic melanoma historically was around about 6 to 9 months, as it says in the title of the slide. And yes, certain groups of people with metastatic melanoma, for example, affecting different parts of the body, the skin or the lymph nodes, or involving the visceral organs, so that would be liver and lungs, for example, there were differences in survival. And the yellow line there is actually people who've got spread, for example, to the liver, and they're the ones that do very worst, as are those who've got an abnormal LDH, so that's lactate dehydrogenase. It's a sort of measure of inflammation in the blood. So that's the historical background. And although so-called cytotoxic chemotherapy, so traditional chemotherapy drugs, had been used to treat melanoma once it had spread, they were largely, unfortunately, ineffective. And these data were published sort of 10 or 15 years ago now. So that was the historical experience. So what about cancer and the immune system? Well, again, apologies if this is a little technical, but the function of the immune system is to recognize and destroy foreign cells or invading pathogens, so viruses, bacteria, and also tumour cells. And one of the ways that cancers grow, one of the reasons that cancers grow, is because the immune system fails to recognise them. And this cartoon here on the right sort of hints at the complexity of the immune system. So if we just sort of start here with cancer cells, if cancer cells are destroyed, they can release antigens, so that's often proteins from inside those cells. Those antigens can be taken up by specialized cells and presented to something called T cells, which are the key immune cell that I'm going to focus on. Those T cells can become memory T cells, so that's important, for example, in the context of infectious diseases, where if you have an infection, and everyone knows about infections more in the last couple of years or so, I suspect, than they did previously in immunology. But if you take COVID as an example, one of the reasons people develop immunity to COVID, if they've been infected, is because they developed memory T cells. That's here. So if you've got T cells that have been activated as a consequence of cancer cells dying, it can become amplified, and then those T cells can go back to the site of the cancer. But there are various mechanisms that can also inhibit T cells, and that's one of the reasons that cancers may be able to grow. So the idea of cancer immunotherapy in this purple box is to try to use the immune system against the tumour rather than killing tumour cells directly, which you might do with more traditional types of cancer treatment. So, for example, surgery, radiotherapy, chemotherapy I've mentioned already, and even targeted therapy in the last 10 or 15 years. So, what is cancer immunotherapy? Well, the first thing to say, and many people will know this, is cancer immunotherapy is not new. I've picked out an example here of a surgeon, William Coley, actually in the 19th century, trying to use a bacteria to treat cancer because he'd noticed that after someone had a bad bacterial infection, a patient's tumour disappeared. So this idea of cancer immunotherapy is not a new idea. But, as you can see here on the right, in the last sort of 20 or 30 years, there's been much more activity, and this is clinical trials of immunotherapies to treat cancer. And there's various landmarks that you can see there some of which over here relate to what I'm going to talk about for the next half hour or so. So not a new idea, but certainly in recent years there's been a lot more activity. Another thing to mention is that sometimes people use the term cancer immunotherapy just to talk about some of the newer drugs that have been developed in the last 5 or 10 years. And I think that can be misleading, but actually there's lots of different potential types of immunotherapy. So for example here, cytokines, so these are actually molecules that cells ordinarily use to talk to each other. They've certainly been used therapeutically in the clinic really for the last 20 or 30 years. Vaccines to try to treat or prevent cancer, and again the idea is the same as with infectious diseases. The idea of using viruses potentially to treat cancer is something that's an active area of investigation, so-called oncolytic viruses. Adoptive T cells, so manipulating T cells and trying to use them therapeutically, and then immune checkpoint inhibitors, so lots of different types of cancer immunotherapy. But I'm mainly going to concentrate on immune checkpoint inhibitors. So this blue blob is a T cell. I mentioned T cells before, the critical immune cell, at least for the purposes of this discussion. So T lymphocytes and cytokines, which I just mentioned, things like interferon or interleukin-2, can stimulate T cells in a relatively non-specific way. Whereas immune checkpoint inhibitors, and there's a couple of checkpoints shown here, actually potentially negatively regulate T cells. So there's some pluses up there and there's some minuses down there, so hang on to that. Now, again, with apologies, and I'm not an immunologist, there's probably a lot of people in the audience who know more about this than I do and are listening online. So how are T cells activated? So first of all, there's 3 signals. The first one is about specificity, meaning that a T cell, shown here, the purple blob on the right, with a T cell receptor, might recognize an antigen from an antigen-presenting cell specifically. So that gives you the specific recognition of an antigen. The next thing is called co-stimulation, and that's an interaction which is shown in cartoon form here at the bottom. So the idea of providing further stimulation. So first of all, recognition, then further stimulation. And then cytokines, again, which I've mentioned already, is the third part of the signal, and they strengthen the recognition. And this is how a naive T cell can amplify in order to generate an immune response. But there has to be a control system for that as well, because if you just had billions of T cells circulating around your body running rampant, they would very quickly cause significant damage. So if you have an amplification, you also need to have a mechanism for controlling it when the immune response is no longer needed. And so indeed, the adaptive immune system has these things called immune checkpoints, 2 of which are shown here, CTLA-4 and PD-1, and I've mentioned before. And the idea, shown on the right, is that the co-stimulation, which I mentioned before, is potentially dampened down by these checkpoints to potentially limit the immune response. Now, this is all shown very simplistically. In reality, there's a lot more complexity here. But the idea of this in principle is that CTLA-4 and PD-1 may act in lymph nodes, which are shown there in green, and that the PD-1 immune checkpoint may be more important actually in peripheral tissues or indeed at the site of the tumour. The purpose of this slide is just to show you, and again we're seeing a T cell in the middle, that there are lots and lots of these checkpoints. There's activating receptors here on the left and inhibitory receptors here on the right, and I've mentioned a couple of these already, but there are lots and lots of these checkpoints in a very complex system to regulate the activity of the immune system. And finally, before I start talking about the clinical applications of all of this, I'm sure lots of people in the audience will already be familiar with this, but the Nobel Prize in Physiology or Medicine was awarded in 2018 to Jim Allison and to Suko Honjo, who you can see here at the ceremony, for these discoveries. And if you read the citation here, the discovery of cancer therapy by inhibition of negative immune regulation. So their work provided the basis for everything that I'm going to talk about and the benefits that we've seen to patients in the last 5 or 10 years, along, of course, with lots of other people in the field. So, to the clinic. So, drugs have been developed to target these checkpoints. And a drug called Epilimumab, which is a monoclonal antibody recognizing CTLA-4, was developed initially by Medarex and subsequently by BMS and started in trials to treat metastatic melanoma about 15 years ago. And remember, I showed you some survival curves earlier on. So what this is about 2,000 patients who are treated with this drug, Epilimumab. It's given intravenously every 3 weeks. And again, if you look at time along the bottom and the chance of survival here on the curve, what that means is that the tail on the curve, in other words, the number of people who are long-term survivors at 3 years and 5 years, and then indeed at 10 years, the curve is flat, meaning that if you're treated with this drug and you survive out to 3 years, let's say, you've got a very good chance of surviving to 5 years and indeed to 10 years. And so with this drug on its own, Epilimumab on its own, there is, as you can see from this curve, a roughly 20% chance of long-term survival from the disease. And remember what I showed you right at the very start, which was that the average survival of melanoma prior to this was 6 to 9 months. So you could say, well, 20%, that's not great, but it was definitely an improvement on what went before. So what does this mean for patients? And this is not my headline. This is Sarah Bosley from The Guardian in 2016. I don't know if you can quite see that citation at the bottom, but it's easy to find on Google. And actually, this is one of our patients at the Marsden. Her name is Sandra Sace. This is in the public domain. I actually spoke to Sandra last week as well to say that I was giving this lecture and would it be okay if I spoke about her. And she was treated with Epilimumab, or Ipi, in about 2005 in one of the early clinical trials. And at the time, and again, all of this is in the public domain, she had melanoma, there were lumps. She had the treatment, and slowly but surely the lumps disappeared. The course of treatment is actually only 3 months of treatment, so she finished the course of treatment. We did the scans were improving. We kept doing the scans up until 5 years, up until 10 years. And I spoke to her last week, 15 years after treatment, and she's leading a completely normal life as a consequence of this treatment. And she's never needed to have any subsequent treatment for her advanced melanoma. So it's all very well showing survival curves, but actually the question is, what does it mean for patients? And this is an example of someone who was treated now 15 years ago for this disease, who is alive and well and living a normal life. So coming a little bit more up to date, and it's more survival curves, I've told you a little bit about Ipi. This is actually a trial where a third of the patients were treated with Ipi. That's the black line there. And as I've told you already, it looks like about 20% of people are long-term survivors, and this is at 6 or 7 years. These data were presented actually last year and published quite recently. But with another checkpoint inhibitor, nivolumab, this is a so-called anti-PD-1 drug. This is in green. You can see that the survival here, again, at these late time points, was around about 40%. And then with the two drugs together, the chance of being a long-term survivor is around about half. And again, remember that the average survival for the disease historically was between 6 and 9 months. And in oncologist speak, these curves are quite flat, meaning that not many people are now dying. So at the very start that happened, but once you're getting out to around about 2 or 3 years, it doesn't really seem that anyone is dying of melanoma. And actually, from this trial, we also published the melanoma-specific survival. So what does that mean? Well, if you say survival, it means you could die of melanoma or you could die of something else. This is the people. It takes out the people who died from other causes. And of course, if people are living a long time, they can start dying of other things, vascular disease and so on and so forth. So this is melanoma-specific survival from this trial. And I think this is the first time this has ever actually been published in a similar trial. And you can actually see in terms of melanoma-specific survival, it's even higher than 50%. So the next question is, how do you define cure? If you think back to my title, you know, okay, maybe someone had treatment 15 years ago, but are they really cured of the cancer or not? And one definition of cure might be to return to a normal life expectancy for your age and general level of health. So I don't think formally we can say that these drugs, checkpoint inhibitors, are curative for metastatic melanoma because we just haven't been using them long enough. And it might be that in the future, people who've had these treatments, their cancer's destined to progress. That doesn't seem to be the case based on the data from the trials and also certainly from my experience and colleagues around the world, that people who've had these kinds of treatments and respond to treatment seem to return to a normal life and a normal level of health. But it is, if you like, formally quite an important point. Can we really say at the moment that this is a potentially curative treatment? So what about other cancers? I've talked about melanoma, which was the cancer, I think, that these drugs were initially first developed in. But actually, these kinds of drugs have now been approved and are available to treat lots of different types of cancer. So, for example, kidney cancer, lung cancer, bladder cancer, colorectal cancer, cervical cancer, head and neck cancer, and Hodgkin's lymphoma. Now, this isn't to say that everyone who's got lung cancer or bladder cancer or some of these other cancers may be suitable for treatment with these kinds of drugs. And actually, in some situations, and colorectal cancer is an example of that, it's actually quite a small subgroup of people who've got colorectal or bowel cancer who are suitable for these kinds of treatment. But the general point I'm trying to make is that actually it's not just about melanoma. There are actually lots of different types of cancer where we've seen benefits from these kinds of drugs. Just to show another example, and this is kidney cancer actually treated with the same drugs that I showed you before, nivolumab and ipilimumab. Again, it's a survival curve. And again, the follow-up here is at about 5 years or something like that. Kidney cancer, which I also treat, is a disease that once it had spread again in the past, average life expectancy was probably about 12 months or something like that. And again, that we can see here, if we're looking at the average, which is around about there, you can see that at 5 years or something like that, around about half of people are still alive having had this immunotherapy treatment. The oncologists and others in the audience might be asking about this other line, which was the control arm of this particular randomized trial, which got a standard drug, which is called sunitinib, which is not an immunotherapy drug and probably doesn't lead to long-term control of the disease. But what tends to happen in these kinds of trials is that if people have another treatment and it stops working, in kidney cancer, many people were actually able to get access to immunotherapy drugs subsequently, which would then, in principle at least, give them the possibility of long-term survival. So that is, before anyone asks, I think part of the explanation for why people in the control arm are doing as well as they seem to be in this trial. So what about non-small cell lung cancer? So not a disease I treat, but I am going to show you the historical survival for stage 4 metastatic non-small cell lung cancer, which was 10% or less. And I think most people would be familiar with those kinds of figures. And if we look at a clinical trial where people with non-small cell lung cancer were treated with pembrolizumab, which is another anti-PD-1 drug made by Merck, actually. The pembrolizumab people are in this blue colour here. Those treated with chemotherapy in the sort of magenta colour there. Again, if we're looking out at 5 years, we can see, at least in this trial, relatively small number of patients, but nevertheless, about 30% of people are still alive, and compare that with the historical 10% or less. And again, if we look at the control arm, before anyone says anything, these are people who are treated with chemotherapy, which would be a standard treatment for non-small cell lung cancer. They actually seem to be doing better as well, but if you can read the small print, it's exactly what I just said, that some of the people in the chemotherapy arm, in fact quite a lot of the people in the chemotherapy arm, just over about 2/3, the chemotherapy stopped working, and then they were able to cross over and then receive the immunotherapy treatment afterwards, again giving the potential of controlling the disease in the long term. So what about other checkpoint inhibitors? I'll put my cartoon up again, which is to show that there's lots of potential immune checkpoints that can be in principle targeted with drugs. I've talked about Epilimumab, which targets CTLA-4. I've talked about Nivolumab and Pembrolizumab that target PD-1. Another immune checkpoint is LAG-3, shown there. And these are some really recent data that were only actually presented last year. You can see that the follow-up is pretty short. This is something called progression-free survival, which again for the non-oncologists gives an idea of the period for which a cancer is controlled, i.e. progression-free. And that we can see that with Relatlimab, which is an anti-LAG-3 monoclonal antibody in comparison with Nivolumab, that the patients are doing better. And actually this led to the FDA, Food and Drug Administration, approval of this combination of drugs, so a third checkpoint, about a few weeks ago for the treatment for advanced melanoma. So it's not just about CTLA-4 and PD-1 or PD-L1. So there are lots of open questions. A critical one, I think, is how do we choose those who are most likely to benefit from treatment? Clearly, the treatments don't benefit everybody. There's been an enormous effort in the last 5 or 10 years to try to find markers, biomarkers, to identify people who are most likely to get benefit from treatment. Frankly, to summarize a lot of work, in some situations there are markers that can be useful. So, for example, something called PD-L1 expression on either tumour cells or the cells surrounding the tumour can be useful in certain situations. There are other markers that, at least in studies, seem to be useful of giving an idea of whether people will get benefit from treatment or not. But do we have anything that we can really use in clinic, say to treat melanoma, to say, you've got a really high chance of benefiting from this treatment, so we're going to give you it, and you've got a really low chance, so we shouldn't? The answer is no. So that's still, I would say, a major ongoing effort. Part of the same question is biologically why are some cancers sensitive to treatment and others resistant. And again, there's quite a lot of work on this actually, and there's some really interesting observations and associations, but again, anything that we can really use in clinic to say, well, actually, you're going to be sensitive and you're resistant, or you're resistant for such and such a reason, so we'll do this. Not really at the moment, I don't think. How long should we give treatment? That might sound potentially unimportant, but actually it's not. It's really important for patients. Is this a treatment you should give once, 3 months, a year, indefinitely? We don't really know a lot of the time, but the whole idea of immunotherapy, at least in principle, is to try to stimulate the immune system to recognise and destroy the cancer. So you'd hope in principle that actually it might not need to be an indefinite treatment, and ideally something that you could give for a short period of time, stop the treatment, and then the patient doesn't need to keep coming back to hospital for treatment. But actually with these relatively new drugs, we still a lot of the time don't really have a good idea of how long we should treat patients for. So it's an open area for research. And maybe scans could help us, maybe something called circulating tumour DNA. That's something that you could measure in blood. There's lots of ideas about things that potentially could be used, but again, nothing at the moment that's ready for prime time. How to increase cure rate, that's obviously critical. One side of the coin, at least in melanoma, is that it seems that about half of people are potentially long-term survivors, but that means that half aren't. How do we address that? Is it new checkpoints? Is it smarter ways to use the drugs that we have? I haven't even talked about side effects in the interest of time as much as anything, but these drugs cause completely different side effects from the kind of side effects that oncologists are used to treating. And actually, one way to look at the side effects is the fact that in a sense, people can develop immunity against certain parts of their own body. So, for example, they can develop inflammation in the liver or in the skin or in the lungs or in the bowel. We tend to treat severe side effects by suppressing the immune system, often with corticosteroids, which are powerful immunosuppressive drugs, and that generally works quite well. But are there long-term side effects of these drugs that we haven't seen? Well, by definition, we don't know, because we haven't been using the drugs long enough, and I think that's the kind of thing we're obliged to bear in mind. And at the moment, as I just said, we tend to immunosuppress people who get side effects, but actually, is that the right thing to do? Is that the best way to do it? Are there smarter ways to do that? That's also a big area of research, which I think ultimately would have a major benefit for patients, actually, if we could deal with side effects more smartly and more kindly. So just in the last sort of 5 minutes or so, I just want to say a little bit about the future, potentially, of cancer immunotherapy. And I'll just come back to the slide that I showed earlier on. I've talked about immune checkpoint inhibitors. There are all these other potential approaches, one of which is adoptive T-cell strategies. And this type of strategy was pioneered by Stephen Rosenberg, shown here, at the National Cancer Institute in the US, actually from the 1980s. And he's now about 80 years of age, and from what I can gather, still working as hard as ever. The idea of this is that you can remove lymphocytes, T cells, from tumours, so tumour-infiltrating lymphocytes, so-called, take that out of the patient, manipulate them, expand them in the laboratory, and then infuse them back to the patient with the idea that they could help to control the cancer. And just a sort of a cartoon of this, actually, with a product which is called elusial. So it's made of these tumour-infiltrating lymphocytes. What happens if you're a patient is that a bit of tumour is surgically removed, say about a centimetre or a centimetre and a half, and then it's shipped off, at least for this product, and it's effectively manipulated, expanded, rejuvenated in the laboratory, and that whole thing takes about 3 weeks. Meanwhile, the patient comes into hospital. They have some treatment with, actually, these are fairly traditional chemotherapy drugs to try to deplete the immune system, at least to some extent, to make space, to give back the T cells, which are then infused into the patient. It's a one-off treatment. And then after that, a drug called interleukin-2, which is a cytokine drug that's been around for a long time, is given to the patient to try to stimulate the T cells once they're inside the patient, and then the patient is discharged from hospital. So that's the idea of this. And these are some data, actually, with this drug, elusial. It's actually made by a company called Ivance in the US. This is a melanoma trial. This is called a waterfall plot, and the way to read it is that anything below the horizontal line indicates tumour shrinkage. You can see, if you count along there, this is sort of about 50 or 60 patients, but this is a group of patients with metastatic melanoma who had exhausted all standard treatments. They'd had checkpoint inhibitors, they'd had targeted therapy, they'd had everything else. There were no good, effective systemic treatments available. And you can see really what I would say are quite dramatic levels of tumour shrinkage in a high number of the patients. So this is potentially an exciting approach. We treated patients at the Marsden with this type of approach, so it's not just confined to the National Cancer Institute in the US. This remains an experimental approach at the moment, but I think the data look really encouraging. And there is, I think, the potential to see approval by regulators for this kind of approach in the relatively near future, at least I hope so. So to summarise, historically, almost all metastatic solid tumours were incurable. I think checkpoint inhibitors are probably curative in some patients with advanced melanoma as well as kidney and lung cancers, but ultimately we need further follow-up. We just need to see what happens in the long term, and the same is true for some of those other cancers that I mentioned. But I would make the point again that half of our patients with melanoma will still die from metastatic melanoma, and more than half of people with metastatic kidney cancer and metastatic lung cancer will die from their disease. But the success of immune checkpoint inhibitors really has revitalised cancer immunotherapy, and I hope and I expect to see further significant progress in the next 15 years or so. So with that, these are my acknowledgements. So I'd like to mention our patients and their families. So all of this has been based on laboratory research, as I showed you before, but also clinical research, clinical trials to demonstrate the benefits of these drugs. Doing clinical trials is a complex business and it requires a big team. And I'd mention my colleagues Kim and Lyra at the Marsden, who run our clinical trials team. And also this is fundamentally a collaborative effort, actually, between academia, between clinicians, industry, government, and actually critically patient advocacy groups as well. So I would like to acknowledge that, and thank you all for your attention.
James, so you were going to sit over there, James. Thank you so much. I mean, that is absolutely fantastic. Miraculous, I think, is the word. In my lifetime, the outcomes from these patients who seem destined to die is completely transformed by these treatments. Obviously, there's a whole long way to go. And the second word, miraculous one, lucid too, because this is such a complicated subject. And I hope everybody in the audience was able to understand that very clear presentation. So we will try and take some questions from the audience. Ione, have you got the microphone there? I bet these two will answer the question. No? Come on, Jonathan. Let me ask a question. You didn't talk about expense. These treatments are pretty expensive, aren't they, James? Tell us about the costs.
Is this working? Is this working?
Yeah, working.
Yeah, so monoclonal antibodies are relatively expensive to produce. Drug companies spend a lot of money developing drugs and doing clinical trials, and a lot of those trials are negative and they don't lead to approval of the drugs. So it's a sort of relatively high-risk business. If drugs are approved, then obviously they need to be priced by the drug companies, and actually drug pricing around the world is quite variable, is the long and short of it, basically. But what I will say, to sort of answer the question at least, is in this country where we have NICE, which is National Institute for Health and Clinical Excellence, the efficacy, in other words, how well drugs work, is looked at, and the cost of the drugs is looked at as well, and it is determined whether or not, by NICE, these drugs should be available on the NHS and represent value for money from a health service funded by central taxation. And yes, they're expensive, Roger, but actually most of these drugs, all of these drugs actually that I've shown you, are available on National Health Service to treat melanoma. So it's actually a complicated subject in its own right, and there may be people in the room with strong views on it, but if we're talking about potentially curative treatment, then maybe that's something that is a potential priority for society, I would say.
Any questions there? I knew Carol secured.
Something about cost.
The gentleman with the glasses and the white shirt first, then Carol.
Thanks very much for an excellent talk. I wonder if you could comment on the combination of checkpoint inhibitors and other immune therapies, such as, for example, oncolytic viruses, and if you see that as sort of a way to further improve cure rates or response rates.
Yeah, I mean, the answer in principle would be yes. I mean, I'm sort of open-minded and agnostic in many ways about combinations. I mean, what I haven't shown actually is that in the last few years, there have been quite a lot of combination trials, particularly in melanoma, which have been disappointing. I think one of the problems is, and there was an editorial in New England Journal of Medicine about this last week or the week before, that since checkpoint inhibitors have come along, there's almost been the term that was used, I think, was a wild west, where basically there have just been lots and lots of combination trials of things being put together, potentially without a strong enough scientific rationale behind it and early data to justify doing these kinds of large trials. So what I would say about combinations is that they need to have evidence, they need to make sense. If you're putting drugs together, they'll almost always have more side effects, and that might be okay, but only if you're seeing more benefit from the drugs. So I would be very open-minded, and I deliberately showed lots of different types of immunotherapy because I think, the field's really open now. I remember actually when I first started doing this sort of 15 years ago or something like that, you used to go to the immunotherapy sessions at ASCO, the big sort of American oncology meeting, and there'd be no one in the room because people just weren't interested. And now, probably they have to have the biggest rooms for the immunotherapy session. So it's been a big change in a short period of time.
Thank you.
The cost is the real... Yeah, hang on, Karen, just wait for the mic because the people online won't be able to hear otherwise.
The cost is a real problem with these drugs. We're talking about maybe £250,000 for a couple of years for one, and then 500,000 to keep someone alive. If you could only predict which 50% would respond by some testing, and what struck me as an observer over the last 5 years, we've not got better at predictive testing for immunotherapy. Why is that? I mean, PD-1 and PD-L1 are sort of vague markers like estrogen receptor.
Yeah. Well, no, I mean, it's a great question. It's not for want of effort, because a lot of effort has really gone into this, a lot of resources, a lot of smart people, and I would say actually quite serious efforts by a lot of big pharma companies to really look at this. And ultimately, the immune system's complicated. You know that. We all know that. And I think if there was something easy, to be blunt, it would have dropped out already. I mean, if you compare with targeted therapy to treat melanoma, let's say BRAF, it's a straightforward technical thing to do to measure whether a BRAF mutation is there or not. Apologies for non-oncologists. And then to isolate the group of people that's going to benefit. If you take PD-L1 expression, it's inducible, it varies over space and time, you've got all sorts of problems. So I think the answer to the question is because it's a complicated problem. On cost, I actually... Getting back to what I said when I was speaking about duration of therapy, the standard amount of treatment now for metastatic melanoma with these drugs is 2 years of treatment. And yeah, the drugs can cost of the order of, let's say, £150,000 a year, something like that. Does everyone need 2 years of treatment? I strongly suspect that they don't. And getting back to the principles of immunotherapy, nivolumab and ipilimumab together can often cause bad side effects. Most people will know that. And if you get bad side effects, you tend to stop treatment straight away. So I've had dozens of people now I've treated over the last 10 years. They've had one infusion of both drugs and we stopped for side effects, and they're long-term survivors. So there are some people who are very sensitive and don't need much treatment. The problem is, I'm afraid, to your point, we just don't know how to identify them.
We've got a little cover of senior oncologists over here. So we'll go to those three, and then I've got 16 questions through, so we better answer some of those questions. But Jonathan Waxman from Prostate Cancer UK
Is that where I'm from? You've tracked me.
Come on, Jonathan, ask your question.
So James, do you have any ideas why the two curves when you compare renal cell cancer and metastatic melanoma, are so different, with the melanoma curve plateauing and the RCC curve just continuing to exhibit attrition. So
I should have mentioned that, Jonathan, because when I was putting the talk together and last week, you're absolutely right, and it comes back, or at least what I would want to see is the kidney cancer specific survival, because what I'm thinking with kidney cancer, it's a disease that people are probably 20 years older on average than melanoma. They're generally less fit. They've got one kidney. And I wonder if some of the people with kidney cancer are actually dying of other causes at these later times, So and in fact, I didn't just think this. I actually sent an email to the relevant drug company, shall we say, that's done these trials to say, hang on a second, we've done melanoma-specific survival. I'd really like to see the kidney cancer-specific survival, and I'd really like to see the lung cancer-specific survival, because that's exactly the point. If your cancer's under control or cured, you're going to die of other things. So that I don't know the answer to your question, but that's what I'm thinking at the moment, shall we say. And of course, the other thing is that melanoma, without question, is the cancer that's most sensitive to these drugs. The sensitivity of kidney cancer is probably about 2/3, and lungs probably about 1/4. So, there may well be people who are not getting the same level of benefit from the treatment as well.
Tim, have you? Yeah.
Yes.
Tim Oliver.
So one of the things which has been well recognised for a long time now is that in all tumour types, there are percentages that lose their major transplant rejection genes. And when I did work with IL-2, it was emerging very clearly that those which retained their IL-2 were the ones who responded to IL-2. And this was in 5 and 10-year survivors. So, and I can't remember where I saw it, but I was at a meeting, I think in the JCO in San Francisco, but somebody came up that checkpoint inhibitors are also far more effective if the tumour has been retaining the MHC. Do you know if that data is really coming?
I'm not sure is the honest answer to that. I mean, to what Carol Sakura just said, I mean, we have been able to identify some things that are potentially helpful. So tumour mutational burden is probably one of those things in melanoma. PD-L1 expression's been pretty disappointing. Inflamed tumours with infiltration by CD8 lymphocytes seem to do better. But the problem is you've got all of these things, and they're all none of them are sufficiently stringent, shall we say, to actually say this is someone you should treat, or this is, which is what you need in clinic. And it's almost as if you need a composite of these different factors to try and help with decision making in clinic. But if I was a patient and someone said, well, actually, you've still got a 10% chance of responding to this treatment and you might be cured, I'd probably want to take it. So I thought what the point I'm making is you need a really good test for clinical decision making.
But you might like to
but not. You can talk a little bit after, because I've got 20 questions here, and I can't see the people at the back. So if you were desperate to ask a question, come closer to the front. A really good question here from Surinder Port. Have checkpoint inhibitors been used for metastatic breast cancer? Because that's a big, big problem, isn't it?
Yeah, it's an excellent question. And I mean, just to broaden it out briefly to other common solid tumours, prostate cancer, breast cancer, bowel cancer. There's a small group of people who've got metastatic bowel cancer who seem to get benefit. With breast cancer, I don't treat breast cancer, but in triple-negative breast cancer, which is a subset of breast cancer, there appears to be some benefit from some checkpoint inhibitors. But again, that's a fraction of people with breast cancer. These drugs have been tested extremely widely against all sorts of different types of cancer. And so for the majority of people with breast cancer, the answer is that unfortunately these drugs don't really seem to help.
There's a question from Alan Dawson. Melanoma and lung cancer are tumours with high tumour mutational burden and may lend themselves to immunotherapy. Do you think that immunotherapy has a role in tumours with a low mutational burden, for example, pleural mesothelioma or glioblastoma?
Well, yeah, I mentioned tumour mutational burden a minute ago, and typically smoking-induced lung cancer and melanoma, because of ultraviolet light exposure, have a high tumour mutational burden, in other words, numbers of mutations in the tumour, and that definitely is a predictive factor. Interestingly enough, again, I don't treat mesothelioma, but I know that checkpoint inhibitors actually can sometimes be effective in mesothelioma, but kidney cancer, and this is the best example, has a low tumour mutational burden, without question. And checkpoint inhibitors, if anything, are more active in kidney cancer than in lung cancer. That remains completely unexplained at the moment. No one understands, really, I don't think anyway, why we see the levels of activity that we do with kidney cancer. But, you know, fundamentally, even going back to the old days of cytokines and everything else, I'm not really sure there was ever a convincing explanation why kidney cancer was so sensitive to cytokines. So, again, something we're interested in, but I don't know the answer.
And there's a question from Rainer Clocker. Thank you, Rainer. Thank you, very clear and impressive talk. I'm a rheumatologist. Can you tell us about contraindications? My experience from one oncologist, that existing inflammatory rheumatic disease is taken as an exclusion to immunotherapy. What would you say to that?
Yeah, well, I think there's relative contraindications and absolute contraindications. Again, apologies for the medical jargon. But we know that people who've got pre-existing autoimmune disease, so joint problems in that example, are more likely to get a flare of their pre-existing autoimmune disease with checkpoint inhibitors. But on the other hand, if you've got a metastatic cancer, you're at risk of dying of your metastatic cancer in the following period of time. So I would normally have a conversation with the patient and with their family about the potential benefits and the potential risks of treatment, and I would generally not regard pre-existing autoimmune disease as an absolute contraindication to this type of therapy. The absolute contraindications are probably solid organ transplants, because anti-PD-1 therapy can cause acute rejection of solid organ transplants. So someone who's got a cardiac transplant or a liver transplant, for example, if you treat them with an anti-PD-1, they're highly likely to acutely reject it and die. But we and others around the world have treated people with kidney transplants in consultation, obviously, with nephrologists. And again, we've had the benefit-risk discussion. There's a risk of dying of metastatic cancer. There's a risk of acutely rejecting your kidney transplant with a checkpoint inhibitor. And most patients, in my experience, will actually say, well, I'm prepared to take that risk because I don't want to die of metastatic cancer. And we've caused renal transplant rejection. But that's something that can be fixed, right, with a dialysis machine. And then the patient's cancer is under control. So, you know, to summarize the answer, I think a lot of the quote-unquote contraindications are probably relative, and it comes back to having a benefit-risk discussion with the patient, like many things in medicine do.
You might not be able to answer this question, but I have a daughter of a friend of mine who's had a triple-negative breast cancer removed. She's had chemotherapy, standard chemotherapy, plus immunotherapy. And she's now developed Addison's disease because apparently her pituitary is conked out as a result of the immunotherapy. And they're telling her that she's going to have steroids for the rest of her life.
Yeah.
What would you say to that?
Yeah, well, one of my endocrinology colleagues told me I was the leading cause of pituitary failure in the south of England a few years ago. So, yes.
Why? Give us a bit of an explanation.
Yeah, well, absolutely. So, in terms of side effects, I talked a bit before about developing inflammation in various parts of the body causing side effects. And endocrine organs can absolutely be affected. And what generally happens is you lose the function of that endocrine organ. So, for example, you can get inflammation of the thyroid, thyroiditis, and then subsequently people can become hypothyroid, in other words, have low thyroid levels and need to take thyroxine. Not normally, you know, too troublesome. But you can also develop pituitary failure, the pituitary being the organ at the base of the brain that people describe as the conductor of the endocrine orchestra. And in that situation, yes, you would need to take replacement physiological doses of steroids and potentially thyroxine as well. You can also actually develop diabetes as a consequence of these types of drugs. The chance, I quote patients, about a 1 in 300 risk of developing diabetes. Obviously, developing diabetes is not trivial because it means you need to have therapy with insulin. And the thing about the endocrine side effects, in contrast to almost all the other side effects that you see with these drugs, is they seem to be irreversible. So people need to then have lifelong replacement therapy. There are a few cases of people recovering endocrine function, but basically it's rare. So, and it comes back to what I said before, that if you're talking to someone, these are some of the benefits and risks that you need to talk through.
Really, really interesting. A question from Madina Amraslanova. Maybe she's from Ukraine. If she is, good luck to Ukraine. Can genetic engineering be used to make immune checkpoint inhibitors more effective?
I don't know the answer to that. I mean, you know, monoclonal antibodies are already highly manipulated. I mean, that's how you make monoclonal antibodies. You know, is that genetic engineering? I suppose it is at the end of the day. But I think genetic engineering has slightly different connotations.
Yeah. Any more questions from the audience? Yes, there's a hand there. Iona, can you just give a mic to the lady around there? Thank you very much. Just wait for a minute. Yeah, she's going to rush across there. Good for her. We've got just a couple more minutes before we're finished.
What about brain tumors?
Brain tumours. Good question. I was thinking about that too.
Yeah, so I'll first of all make the distinction between primary brain tumours, tumours that start in the brain, versus spread of other cancers to the brain. So melanoma, for example, very commonly spreads to the brain, and about a third of people who've got melanoma that spread, the brain will be involved. And in that situation, actually, these drugs, immune checkpoint inhibitors, seem to work pretty much just as well in the brain as they do in other parts of the body, presumably because the immune system, in that, at least in that example, can be active in the brain. And actually, one of the things I was very worried about 10 years or so ago when we started using these drugs is whether or not they might not work in the brain, and we would end up with a load of people who actually had spread of the cancer to the brain where it was controlled elsewhere, which is one of the things that actually happened with cytokines kind of back in the day. In terms of primary brain tumours, which might be what your question was referring to, there's some activity, I think, for these kinds of drugs in primary brain tumours, but not a particularly high level, to be honest. So they haven't had a major impact, I don't think, on the treatment of primary brain tumours, unfortunately.
I think on that note, since it's 7:30 now, we better stop. So thank you so much, James. Just stand up for a minute, because now the ceremony, this is the medal, the Stevens Medal. We have Lord Stevens here, Howard Stevens here, Rupert Stevens here. The Stevens family are in the front row. This has been going for 52 years, as I mentioned, and this is the medal printed by the Royal Mint, and you can display it on your mantelpiece and impress your friends and family. So a round of applause for a really special talk. And the good news is there are drinks outside in the atrium, so you'll be able to grill James and ask him even more questions outside. So thank you so much, audience. Thank you, people online, 300 people online, around 200, I think, here in the auditorium. It's lovely to have you back again in the auditorium after 2 years of COVID where we haven't had people here. So have a good evening, everybody. Bye.